speaker. It's a virtual only presentation today, and I will just ask everybody to make sure that they're on mute. For the land acknowledgement, we acknowledge that Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence has nurtured and continues to nurture this land. CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land. And it's my pleasure to introduce our speaker, Dr. Laurent Renesme, an assistant professor in neonatology at the University of Ottawa and CHEO. He's an active member of the Green Committee of the French Neonatal Society, contributing to guidelines on developmental care in neonatal intensive care units. Laurent participates in the EPIC Family Engagement Group to advance family-centered practices and is involved in developing a Canadian Neonatal Bill of Rights with the Canadian Premature Babies Foundation. His work focuses on improving neonatal outcomes through evidence-based care and advocacy for newborns and their families. So I'm very excited to hear his presentation today, Developmental Care in the NICU, Neuroprotective Strategies for Optimal Outcome. So I'll turn things over to you, Laurent.
Thank you for the introduction and good morning, everybody. It's my pleasure to have the opportunity to share with you around developmental care. So part of this presentation I presented part of this presentation to the Premier Talk of the Canadian Babies Premature Foundation last month. So today my goal is really to try to give you an overview about developmental care, what it is, and also why it does matter in our NICU setting. And I will finish this talk to try to describe how we can support the implementation of such strategies in our daily care. To start, I think we need a bit of a background to understand where we come from in terms of neonatal care, and also how our vision of the newborn has changed over the last century. So if we look at neonatal care in terms of care we provide for the most sickest baby, the pre-NICU era started at the end of the 19th century. And the two big pioneers for this were these two French obstetricians. So at the top, you have Stéphane Tarnier, and the bottom is Pierre Budin. So both of them, they were instrumental in developing what was the first intervention in terms of neonatal care. So they implemented in their unit in Paris the first incubator, and they also developed tube feeding and also providing pasteurized co-milk for the babies. And soon after, it became obvious that we needed to develop units specialized in newborn care. And so you can see, like starting in the mid-50s and 60s, the first NICU started to open both in Europe and North America. As a result, now we have more dedicated team to take care of those sick baby. As a result, the survival of such baby started to increase dramatically, especially in the 80s. And especially in the population of the lowest birth weight. In the 90s, like the two major advances in terms of neonatal care were the antenatal steroids and the surfactant. And the thing is, since we did a lot of progress in terms of technical care, our ability to have like central line for those small baby and to provide support for the nutrition, etc. But the survival and most importantly, the comorbidities and the outcome of those patients didn't change much over the last decades. And so you can see on the timeline, I placed the developmental care early 2000s. We need to acknowledge like many things happened before that, but this landmark of 2000 is really when developmental care started to be a thing in the NICU. When we talk about developmental care, we need to talk about these two very important people. At the top, you can see this is Dr. Brazelton, and the bottom is Dr. Hals. Both were working in Harvard, and they both changed our vision of the newborn. So their work was very important. It was like during the late 70s and the 80s. And it changed completely the way we were looking at the newborn. Before that, the impression was that the newborn, even the term newborn, were just born as a blank state, with no previous experiences, no learning, and very limited competency. And most likely they were, surviving thanks to their primary reflexes and the care of their parents. But Brazelton and Hals, so Brazelton was working mainly on term baby, and Hals further continues this work in preterm baby, were able to show that indeed newborns are competent and capable beings if you take the time to observe them and using their tool they developed. We figure out that indeed those newborns already have some knowledge and are also able to interact with their environment. And so those two people were key to develop more humanized and individualized neonatal care in our units, both respecting the infant cues and also supporting the families. To understand why developmental care is important, we need to understand what is supposed to happen during the prenatal life. We know that the sensory development in utero will happen very early, as soon as 7 weeks of gestation. And as you can see on this timeline, even the smallest baby in our unit, the youngest one between 22 to 24 weeks of gestation, they will be already fully equipped to sense the environment. And so what is usually happening in utero, and this is coming from studies using ultrasound from the MFM and the OB clinic to understand what the baby was doing in utero. We know now that there is a life before birth. And now when I'm saying a life before birth, I'm not only talking about the physiological changes the baby is going through, the organ development and maturation. I'm talking about a life of experiences, learning, and connection. So as you can see on the slide, very early on, the baby will start to have movement as soon as 6 to 7 weeks of gestation. And initially, those movements, they are pretty random and spontaneous. This is what we call the motor babbling. And very soon after, because those movements are going to trigger sensory experiences for those babies, they will start to have early goal-directed movement as soon as 10 to 12 weeks of gestation. And so why it does matter? Because those movements and all those sensory experiences the baby is going to do in utero are going to support his learning, are going to develop his connection with his mother, and also are going to nurture the developing brain. So through all these experiences, the baby is going to learn and explore. He's going to explore his body, and this is where you can see the body mapping is happening. And we also know that curiosity and intrinsic motivation are going to develop in the baby in utero. And this is coming from study, antenatal scan, showing that when you look at twin pregnancy, when you do repeat scan during the pregnancy, you can see that as the pregnancy is moving forward, the twins seems to have more and more movement that are targeting the other twins. The other very important part is all this sensory experience is also key and is the foundation of the social and the emotional connection between the mother and the baby. And the last very important part is really about understanding that on this developing brain, the stimulation builds the function. This is where the neural plasticity happens. And because those babies are connecting the neurons and creating synapses, the impact of such stimulation are going to select, the good synapses, the good neuronal circuits to ensure the baby has an optimal brain development. And so when we look about the human brain development, you can see this very critical stage of the brain development called the branching and the synapsogenesis. And you can see on the timeline below that actually most of the baby in our NICU are born at this very critical stage of brain development. And now you can understand that the preterm births are going to expose first this baby to a rupture with the intrauterine stimulation, and will expose them to very abnormal stimulation at a very critical stage of their brain development. So if we look at the preterm birth, we need to acknowledge it's a sudden shift, both for the baby and the parents. If we look at the baby, as we already discussed, even the youngest baby in our unit, they are fully equipped to sense the environment. But they are also very mature in the way they can filter, in the way they can process those stimulation, and also in the way they will behave in response to those stimulation. And that matters because, for example, when babies are exposed to pain, they have a modified perception of the pain, and they will also struggle to actually show that whatever we are doing to those patients, they are expressing sign of discomfort and pain. So it's a challenge at the bedside. On the other hand, because they are very immature and they need a lot of support for their vital function, they will be exposed to a significant burden in terms of painful and uncomfortable procedures. And on the top of that, the NICU environment itself is very inappropriate in terms of neurosensory stimulation when it comes to noise environment, the lights, the smell of the different products. And the last very important piece is about the parents. And I think maybe that's one of the key messages of this presentation is you need to understand that the parents we are having in our NICU are very different to the parents you are used to interact with at CHEO, whether it's on the ward, in the merge, or in the PICU. Why? Because the parents experiencing premature parenthood will be challenged on different levels, and they will be challenged in their role of natural primary caregiver for their baby. And we will see that that's going to trigger a lot of challenges for those parents. And because they cannot assume their role of natural caregiver, then the baby support is not optimal. I don't think I need to show you like tons of slides to explain how different the womb and the NICU environment are. And I think this quote from Dr. Hals is a good summary of it. The NICU is really a feat of human ingenuity because we have a lot of technology around the baby, but we also need to acknowledge this is also a violation of the immature brain's expectation in terms of what should be the normal stimulation and the filtering of those stimulation. When the baby is born preterm, the first thing is really is going to lose this protective uterine environment. So all this natural support for self-regulation and also all this envelope protecting the baby and filtering from the outside stimulation is going to disappear. What is going to happen also is because now the baby is born, will not be exposed to this positive and natural and nurturing stimulation that support the normal brain development in utero. And lastly, because he's sick, because he's in the NICU environment, he will be exposed to very abnormal stimulation in terms of intensity and also the nature of those stimulation. And so you can see how this preterm delivery, regardless of if the baby has a brain bleed or whatsoever, is going to impact the developing brain. When it comes to the parents, the gap between the expectation and the reality of the NICU is exactly the same. Most of the time, parents will expect to have a normal delivery at term and to go home after a couple of hours or days with the baby, a well-grown baby, being able to cuddle and to breastfeed. For the NICU, it's a very different environment. And as you can see on the picture on the right side, showing like the room of a baby, this is usually the first thing the parents will see when they will first meet their baby, because often those moms, they will go under C-section, sometimes under GA. And so you have to figure out that this is the first time they will meet the baby, this is what they are going to see. And the first thing you can see is there is a tons of equipment around the baby, and you can even ask yourself, okay, where is my baby? And so this is where the challenge are starting for those parents. We know from the literature and also from different group and parent association that those parents, they will share common challenges when it came to premature parenthood. The first thing they always report is really they feel very unprepared to what they are experiencing in the NICU. They often also share the lack of recognition as parents, and that's also coming from the family and the friends. We are a bit, it's a bit an awkward situation. You don't know if you should celebrate because the baby is born, or you should be very worried because the baby is unwell. There is definitely a physical and an emotional separation from the baby. And the key aspect here is there is a disruption of the parental role. And all the parents, they report that they struggle due to the inability to fully care for the baby. And stemming from that, is this feeling of lack of control. And we know this lack of control is going to trigger more feeling of fear, anxiety, stress, and also depression. And on the top of that, because the baby will stay for weeks or even months in the NICU, there is a financial burden. There is also all the logistic of, taking care of the daily routine at home, managing the sibling, etc. And so you can see how we can quickly start a vicious circle where all these feelings are going to trigger more guilt, more fear, anxiety, and stress and depression. And I would like to share one story about a mom I got when I was working in my previous unit in Bordeaux in France. So this mom had a baby at 25 weeks of gestation. I was present at birth and I was rounding almost every day for the first month of life with this baby. So I knew this mom very well. And the baby had a rough start. He got a sepsis at some point and he got a query neck. So we had a couple of, I wouldn't say difficult discussion, but serious discussion with this mom. And she was rock solid. Like every day, she was present at the bedside for hours, doing the care with the nurses, doing skin to skin with her baby. And I remember one day the baby was just 1 month old. We did another ultrasound, and the ultrasound result was normal. So I was rounding, and I disclosed this result, and I was, pretty confident it was a positive result for the mom. And right away, she started to cry, and she was very overwhelmed and upset. And I was a bit caught off guard because I didn't understand, okay, what is happening here? I'm disclosing something positive for once, and she's not receiving it as I would like, I would expect it. And so when she started to settle and stop crying, I asked her, okay, can you explain to me what is happening? Because I think I'm missing something. And she shared with me that the same day in the morning when she came at the bedside, she realized for the first time in a month that the baby she was visiting every day was her baby. So it's just to show you that, those parents, they are very quiet. They won't challenge you. But if you don't ask, you cannot figure out and you cannot imagine what they are going through. And so as much as we cannot remove the trauma of the preterm delivery, I think it's our job to make sure we can support them as much as possible by, trying to decrease as much as possible the separation with the baby, trying to reinforce them and to restore them in their role of natural primary caregiver, to support how much, how we can for the financial part and the logistic at home. So now I'm going to give more details about what we call the developmental care. And you need to understand that developmental care is basically a big umbrella term, and you can see many different strategies underneath. And now we are speaking more and more about infant and family-centered developmental care, just to remember that developmental care is not only about the baby, it's also about the family. And so when we look at our NICU environment, we can see there is indeed 3 different ecosystems working together. The first one is the baby. The second one is really the parents and the family. And the third one is our NICU team and the hospital settings. And you can see that all 3 systems, they are very closely intertwined, which means that anything changing in one of the systems is going to impact the 2 other systems. And so that's one of the key concepts of the developmental care. We need to have an holistic approach. We cannot just target the baby or just target intervention on the parents or just target intervention on the environment. If we want to do like a meaningful and impactful change, we need to have this holistic approach. So what are the big concepts if we look at each different system? For the baby, it's really about trying to have individualized care. So knowing the baby, knowing how each baby is going to behave. And again, we should move away from this, he's a 23-weeker, so he's expected to behave like a 23-weeker. No, every baby has a different story, and they all have different, way to interact with the environment and way to cope and self-regulate. The second part about the parents is really trying to develop what we call parents-partnered care. So here the aim is really to empower the parents so they can go back to their role of natural primary caregiver for their baby. And the last part is really ourselves as an NICU team and as an institution with our hospital to work on the environment and to change how we behave on a daily basis to support both the parents and the babies. And the goal of the developmental care strategies is really to limit as much as possible the impact of the NICU on the baby's brain to support optimal brain development. So I think the key message here is to understand that developmental care is not just a nice thing to have or a nice add-on. It should be universal neurocritical care. So all the baby we are caring for, regardless of their disease, regardless of their gestational age, should be able to have developmental care. Here is just to show you some example of what different strategy we can do. And you have to understand those strategies. Basically, they will be either to support like the development of a more supportive environment or more supportive care. And you can see you can play on the environment by trying to reduce the noise, the light, but you can also have more supportive care in terms of pain prevention, management, etc. And so those different strategies most of the time will be combined, and we have more formal programs such as the NICU, which is one of the most well-known developmental care program that was developed by Dr. Hals in the 80s. But in the end, this is the same approach, right? They have the same goal of supporting and promoting the developing brain. And one key aspect of developmental care is really to have this individualized approach. So that means at the baby's level that we need to know how to observe the baby, and we need to know how patient. And at the parents' level, and I think that's also very important, one thing we should stop doing is really we should stop assuming, and we should start asking more often, okay, how are you doing? What are your challenges? How can we help you? Because often we tend to, have shortcut and assume, oh, the parents are not here, maybe they are just resting at home or whatsoever. But again, going back to the story I share with this mom of the baby born at 25 weeks, if we don't ask, we have no clue of the challenges they may face. So on this slide is just a couple of pictures just to show you that even very simple strategies can support the baby. So on the left side and at the bottom, you can see both baby. We use neonatal positioning, and you can see they have a nice nest supporting the back of the head, their back, making sure the baby is in a flexion position. The hands are very close to the mouth to support the self-regulation. And you can see that can support either a good sleep for the baby, or when the baby is awake, that also supports a nice interaction with his mother. The picture at the top is showing you that when we do care for our baby in our NICU, we should provide 4 hands care, which means 2 hands should be dedicated to support the baby, and 2 hands should be there to deliver the care. So you see on this picture, the nurse is helping to support the baby to get a nice fetal taking position, while the mom, we don't see her, she's outside the frame, but she's preparing everything for the diaper change. And the last picture on the right side is just showing you that simple things such as non-nutritive suck can be also very useful for the baby to self-regulate. And you see this baby, we just remove the CPAP for the care. The mom is holding the soother, and now is fully awake and is able to interact with his mother. So we should nurture this time where the baby is stable enough to interact. And having developmental care strategy is going to support those babies to have more and more moments where he can interact with his mother and parents. So overall, the idea is really to restore this balance where we need to try to develop stimulation that are closer to what the baby is supposed to have in utero. And that's coming with the mom, because definitely, everything the baby knows about his mom through the amniotic fluid, the smell, the taste, and everything, that should be bring at the bedside for this baby. And we also need to, rethink the way we are caring for this baby to try to limit as much as possible all the disruptive stimulation that are coming with our intensive care. When it comes to the family, what is important to understand is even though the NICU stay is very short and it's a critical period of their life, right? But it's still a very short period of life if you compare like to a lifelong. What is happening during the NICU is going to be impactful for the whole life. And we know that the role of the parents is key to support the development of their baby, regardless of their condition. And we also know we have effective intervention to support those parents in terms of reducing the stress, the anxiety, and the risk of depression, both in the NICU and after. And so more and more, we are seeing developmental care programs that are developed to support the transition home. And so basically, we are supporting also those parents and family once they are getting home for a couple of weeks or even months. And so, again, if we think long-term outcome, this is a public health issue. If we have early intervention, the impact is going to be long-lasting on this family and those babies. So when it comes to the different intervention we can do to support the parents, there is different layers. The first one you can see at the bottom right is really what most of the NICU are doing. It's parent support intervention. So, having clear communication, some education, a supportive environment, etc. The second layer is when you start to have parents more involved in the care. And it doesn't mean it doesn't have to be like very technical care. It should be also care that can be provided by the parents, such as massage or skin to skin or talking to the baby. And the external layer is really what we should aim for, is to develop a model where this time the parents are completely partner of the neonatal care. And this is what you are, the way you provide care at CHEO with parents on the ward or in the PICU on the MERD, right? They know their baby very well, and they will be the one advocating. They will be the one telling you, I don't think that's a good option for my infant. And so this is how we would like those parents to be in the NICU. The primary caregiver advocating and supporting their infant. So when we look at the principle behind the parents' partner care in the NICU, it's asking ourselves, like a healthcare provider, to develop a more flexible approach where we are going to collaborate more with the parents, respect their choices, share the information, support their strengths to empower them to be at the bedside and deliver the care for their baby. So often when we talk about developmental care, because if you want to do meaningful and impactful changes in our care, it's quite uncomfortable because you definitely need to change the way you are delivering your care. Often people are going to come and tell you, I'm not quite sure about that because I don't have the nice NICU design. I don't have the right setting to do that. I don't have the resources or the equipment to do that. So I would like to share two different models of care that were developed in the late 70s. One was in Colombia and the other one was in Estonia, just to show you that, sure, it's easier to implement developmental care if you have a nice NICU design and if you have a lot of staffing and everything, but you can also do meaningful changes with in a low settings environment. So the first one is really about the kangaroo mother care method. So this one was developed in Bogota in Colombia, because they were facing in this hospital a huge mortality and morbidity in their late preterm and small infants. And that was stemming in the lack of equipment, such as incubator. They were having very high rate of nosocomial infection. And also what is also worrisome, they were facing increased rate of infant abandonment in the hospital. So they developed this intervention based on three principle. The first one is the kangaroo position, and it should be as continuous as possible. You can see on the picture is it's basically holding the baby skin to skin in a vertical position. They are promoting exclusive breastfeeding, and they try as much as possible to discharge mom and baby as soon as possible from the hospital. If the baby is a bit unstable, it will be transferred to a low acuity unit called the kangaroo ward, where they can continue the education, they can continue to support the parents to ensure the transition home will happen safely. And so they showed like very good results at the baby level in terms, on physiological stability, better growth, but also drastic decrease in the nosocomial infection, in the mortality and the overall outcome of those babies. And they were also able to show that actually this type of care, which is very centered on the baby and his parents, is very supportive and empower the mother and the family, and will also promote this emotional and physical closeness that is critical for the bonding between the mother and the baby. And so this KMC method has been furthermore implemented in many, many different countries. And the World Health Organization just published last month a 150 pages document with guidelines to implement the KMC method in neonatal NICU. The second model of care is about the mother-infant neonatal unit. This one is at the Children's Hospital in Tallinn in Estonia. And you see it's exactly the same period of time, late 70s, early 80s. And they were facing similar challenge, such as, lack of staffing. So they have to run a 70-bed unit, half of them being preterm baby, and they only have like 4 nurses for each shift. So you can see how it can be challenging. And so what they developed is this concept of mother-infant neonatal unit. And the principle was the care should be delivered 24/7 by the mother. And so now the mom is empowered to be the one that knows the baby very well. So that was expected for the mom, to provide all the care. If the care was technical, the nurse will come, for example, to put the NG, but all the tube feeding will be done by the mother. It was also expected from the mother to keep track, and writing down the different progress of the baby so they can share with the medical team during the morning round. And also a lot of promotion around the breastfeeding. And one also key aspect was the minimal use of technology and exposure to medical and nursing staff to ensure, the baby is not exposed to nosocomial infection. And so to do that, as you can see on the picture, the mother were rooming in with the baby. They were also nesting, so they were encouraged to bring stuff from home, so the hospital room feel more like home. There was a lot of emphasis on education with the nurses and also the psychologists in the unit. And if the mother needs any type of care, especially OB care, instead of the mom going to the maternity ward, the OB team will come at the bedside, assess and treat the mom. And one other very important aspect is that they were having in this unit a dedicated big room where the mom and the baby can meet multiple times with the entire family and friends to ensure the family and the social connection were happening despite the fact the mom and the baby were in the hospital. And so this mother-infant neonatal unit was developed by Adik Levin, and that is the experience that triggered later on the development of the family integrated care in Canada. So I'm going back to the same thing. If we want to implement developmental care in a meaningful way, we should and we need to change our model of care. Most of the time, this is the type of model of care you will find in the NICU. The baby is at the center of the care, but the first layer, the layer of people that are most of the time in contact with the baby, that are delivering like almost of the care, is the NICU team. And the external layer is the parents and the family. And often they have to ask permission, or can I take my baby's skin to skin? Can I do this care or can I do that? So the idea is really to switch those layers, to keep the baby at the center of the care, but then the next layer, the closest one from the baby, is now the parents and the family. So they are the natural primary caregiver, and they should be the one delivering the care as much as possible and supporting their baby. And then the healthcare provider are the external layer, and their role is to support the family and the parents through education, change in behavior to support the baby. And if you want this to work, you need to have an additional layer. And this time, this is the hospital and the institution. They should endorse developmental care. They should make it a priority to support this deep change in the way we are, practicing the medicine in our unit, to support the healthcare provider so they can support the parents, and at their turn, the parents can support the baby. And for the sake of the space, I didn't show it here, but ideally, you would like to have an additional layer. This time is the society. And in the society, reinforce the importance of parenthood and taking care of such small baby, then the institution and hospital are going to follow and support the healthcare provider to support the family, to support the baby. But the thing is, implementing developmental care and changing our model of care is not very comfortable. And we need to shift our philosophy of care from our classical ICU approach. And again, very important to understand that I'm not saying we shouldn't have this classic ICU approach. Like this is the classic ICU approach is the foundation of what we are doing. We need to deliver safe care. We need to master our skill set. We need to be able to respond to urgency and to be compliant with procedure. But ideally, what we would like is to add this external layer of developmental care approach where we are going to value and work on our cognitive expertise, our emotional competence, and also our reflective capacity. And that is key to move toward a more flexible and individualized care. But we need to acknowledge it's going to be emotionally demanding for the healthcare provider. So to do that, that's why we need the support of the whole institution. One thing when we talk about developmental care, and if people are not very keen to change, the first thing they will tell you is, but what is the evidence? And so that's why I wanted to have this couple of slides to discuss about developmental care and evidence-based medicine. The first thing we need to discuss is what is exactly evidence-based medicine. And I will encourage you to do this exercise with your trainee or even your colleague. Ask them to describe and to define what is evidence-based medicine. I can tell you 100% of them will say, oh, it's using the best evidence available to inform our care. Okay, that's true. That's part of it. And so when we look at the evidence for developmental care, we have, I would say, a significant body of evidence to support most of the intervention we are doing in developmental care. The big caveat here is that developmental care are often complex intervention, and the gold standard of the randomized controlled trial is not a good fit for such complex intervention where often you cannot have a good blinding, etc. So what I'm saying is, if you expect RCT to show you that developmental care is the way to go, it's going to be challenging. Even though, for example, for the NICU, there is, I think, 10 plus RCT showing like positive effect, whether it's the growth or the duration of stay in the NICU, etc. But just to show you that we do have enough evidence, I think, to do that. But if we look at RCT, if we expect more evidence to come from the RCT, it might be a challenge. So going back to the evidence-based medicine, some of the trainee and even your colleague, we might have, okay, yeah, it's taking into account the best evidence, but also our clinical expertise as physicians, as nurses, or as an NICU team. But very few actually will add, and the third very important part of evidence-based medicine, is about patients' value and expectation. And you can see that if you want to truly do evidence-based medicine, you should take into account those three items. If you just use the evidence from the literature, most likely you are not providing evidence-based medicine. And so because the RCT are going to be challenging to deliver this evidence, we found different ways to generate this evidence and also to develop guidelines. And this is just a couple of examples of different associations at different levels. So APQ is from the Canadian Neonatal Network, and since this year we have a family engagement group where both parent association and parent representative are working end-to-end with neonatal care provider, including nurses, RT, physician, etc. The French Neonatal Society, as you were saying, we have the Green, which is a group working on developmental care since 2012, with the same setting, sharing information and developing guidelines end-to-end with parent association. And there is also this very impactful and important association with the Global Foundation for the care of the newborn infants. Initially, that was a European initiative, but since it became something worldwide. And so all those groups are working together with parent association to create the evidence, sharing the experiences among the different centers and developing guidelines to support developmental care. And so this is one example of what we can achieve when we work like this. So we do have now standards for the NICU design. So if you want to do renovation in your unit or if you want to build a new unit, this will give you some insight of what should be the big principle to have if you want to have a developmental care approach in your NICU design. And so some are coming from the States, the one also from the French Neonatal Society, and the other one is coming from the Global Foundation for the Care of the Newborn Infant. And I'm coming to the end of this presentation. I would just like to have a couple of slides to discuss about the zero separation concept and how, and to show you different examples on how we can implement it at different levels. So this is a publication from 2018 from a group in Australia and also a group in Sweden, trying to describe best practice guideline in terms of developmental care. And you can see one of the first items on the list is really about trying to minimize the separation between the parents and the infant. And so they came up with a couple of recommendations on how to do that. And as you see, most of those recommendations were rated as strong recommendation. And so based on that, part of the team that were part of developing those guidelines, working in Sweden, moved on and developed what they call the mother newborn couplet care. So this is a very nice example on how we can work on this concept of zero separation and bring it to the next level. So what they are now doing in this center in Sweden at the Karolinska Hospital, they are working on the zero separation and they change the design of their unit and also the workflow between the obstetrical team and the NICU team to ensure that both the baby and the mother, regardless of the level of care they are requiring, are taken care of within the same room, within the same ward. And so you can see all the changes that you need to achieve to reach this goal, right? It's a lot of rethinking, okay, how we design the unit, but it's also a lot of work trying to connect with the different group of OB, NICU, making sure everyone is working together. And that's a very good example where you see what you can achieve just to target this goal of zero separation. If you remember when we were looking at the different layers of care, I was saying that ideally the most external layer should be the society, and the society should support the care we are providing in the NICU. And so that's what happened in France in 2021. The French government, in association with the Parents Association SOS Préma and the French Neonatal Society, published the first neonatal Bill of Rights. And it was a very simple Bill of Rights with only 10 items. And those are the 10 items. And I think the biggest strength of this Bill of Rights is each item is not prescriptive. Each item is not telling you what to do. It's only telling you what you should aim for. And therefore, there is no discussion around, oh, but I don't have the nice NICU design to do that, or I don't have enough staffing, or I don't have this fancy equipment. No, it doesn't matter. What you need to target is each of these 10 items, how you get there, what will be your journey. It's really depending on, your local situation, what are your facilitator and barriers. But it's really supporting the healthcare provider to work towards this goal of zero separation, for example, as the first item, promoting, the pain management with the parents, etc., etc. So it's just to show you that you see that developmental care is not solely something that should happen in the NICU, but if you want to change deeply, the system, you need to have this external layer and the different support from the society and also the different institutions. So to conclude, I hope now you're convinced that developmental care shouldn't be just a nice option, but really a universal neuroprotective care for our baby. And as we discussed, it's really something that is individualized and based on a holistic approach, taking care of both baby but also the parents. And really, if we want to change the way we care for this baby in a meaningful way, I think, yes, we can start, low with small strategies such as neonatal positioning and everything, but we should aim for something, more complex, and we should revisit and rethink the way we are caring for our babies and our families. So thank you, and I will be happy to take any of your questions.
Thank you very much, Laurent, for that excellent presentation. We'll open the floor to questions. People can raise their hand. I see one from, oops, my screen keeps changing. It's there. Sorry, it wasn't a question. It was a hand clapping. I apologize. Lots of hand clapping. Please feel free to unmute yourself if you have a question. And then if there's any follow-up questions, just raise your hand, please.
I think we have Jessica Duby.
Yeah, Jessica's there. Please go ahead, Jessica.
Hi, Laurent. First of all, thank you so much for a wonderful presentation that I think could enlighten both us that work in the NICU with you and all other specialties that will often see these babies either in the NICU or after their stay in the NICU. I guess I have more of a practical question, right? So a lot of what you're presenting is the ideal, and in real world, especially if we look at the general, at our own facilities, there's a lot of practical limitations in terms of space, in terms of culture. So I'm thinking that, the nurse that wakes the baby every 3 hours because they have three babies to take care of. Is there a certain sort of first step, at least in our own institution, given all the limitations, that you would recommend to reach that kind of utopia that you talked about today?
Yeah, I think the first step is really to raise awareness about developmental care and why it does matter, and also to build this foundation of a common culture about neonates, because I think that's key. As soon as people understand why it's important, and as soon as we all speak the same language and we all understand, what are the consequences of what we are doing, that's the very important first step. Because again, like meaningful changes, it's coming with a lot of discomfort, right? It's painful to change, and especially it's painful if we ask you, okay, maybe you should run differently, maybe you should be, change the way you are doing things since ages, and we are not trained to do that. Since our training, we are trained in a more dogmatic way to say, okay, what is the evidence? It's just I have one way to say this and everything. So it's really about working on, what we call the confident humility and being able to rethink the way we are caring. So what I did in my previous unit in Bordeaux, we were having the same issue with different neonatal intensive care unit, PICU also taking care of part of the population, and the pediatric cardiac ICU also. And so what we ended up doing, because we didn't have enough funding, for example, to implement a program such as the MidCap, okay? So what we did is actually we built our own training where we had people from outside our hospital coming, giving lecture around developmental care. And so all the people taking care of newborn baby at the University Hospital of Bordeaux were trained for that. So it was more than almost 400 people over 2 years. And then what we did is for each unit, we asked those speakers and leader in the field of developmental care to come and visit each unit, do some audits, define priority to work on with each unit, and then after having on-site guidance and follow-up, just to create the momentum. Because the thing is, as soon as you change your care, it's going to be painful, but it's extremely rewarding. So you know what I mean? It's just how we can make people understand this is important and it's worth it. And when you try it, I'm pretty sure you will adopt it.
Great. Thank you so much.
Thanks, Jessica. And James, please go ahead.
Is that James meaning Jamie? My name is Jamie.
Meaning Jamie? I was just going with your name on your.
Yeah, no, I saw that. Thank you. Thank you. Thanks, Laurent. I have a few questions, but I'll organize them into two. One is I'm just interested in the a bit more specifics about the evidence for. So this is a really interesting presentation. I was focusing in maybe on the Estonian study showing really care by parent with a reduction in nursing staff, and I'm wondering about if you have the specific evidence for how that impacted outcomes. I wondered in studies or in meta-analysis what the outcomes are. Like, did you look at did they look at survival, neurological outcome, and quality of life for the parents, or impact on the emotional well-being or psychological well-being of parents in that case, or is it just too early that? And then as part of that question, I'm wondering if there are plans globally to do some kind of comparative effectiveness research, stepwise randomized trials, things like that. And then second question I'll leave, that's a complicated first question, so maybe I'll leave the second one for a little bit later.
Okay, thanks. Yeah, I think it's a very important question about the evidence. So I think there is multiple layers in this question. The first one is, as we discussed, all those strategies, they are complex interventions. So how do we provide evidence on this? It's a bit challenging. Like the RCT is definitely not a good design for this. The second important part is also to understand that even now in 2025, we are still running clinical studies inside the NICU where we look at outcomes that were defined only by medical doctor or NICU team. So what I'm saying is we are trying to move towards something where the outcomes are actually defined by the parents, like outcomes that are very impactful for them or meaningful.
Excellent.
And so I don't know yet, and you can see how the complexity of it, because it's a complex intervention. You have so many things you do in the NICU. And I think it's also important to understand that the claim of developmental care was never to improve death, or at least, you know, in our setup. I'm not talking maybe in the developing country, it's a bit different maybe. But the aim is not to, you know, reduce the amount of death or even IVH. It's really to empower the parents, support the parents, to limit the impact of the trauma on both parents and baby, with the expectation that if the parents are doing okay, they will be able to support the baby, even though if the baby later on will face like challenges. And so I think there is evidence to support that if we do early intervention on the parents, they are doing better after, for sure. We do have evidence to say, like, if the parenting is doing well, the baby are doing better. So after you just, you know, connect the dots and try to come up with the answer. But I think it's a building the evidence for this. It's hard, and it's maybe we shouldn't look at the conventional way we are building evidence for other things such as medication and intervention. But to be honest, when you look at all the care we are doing in the NICU, people are very keen to treat, for example, the ductus arteriosus, even though we have zero evidence to support that. If you do that, you'll change the outcome of your patient, right? So it's always the same. The more complex is the intervention, and especially if the intervention is asking you to change the way you practice your medicine or the way you think, the less likely you will, you know, implement it, because it's again not very comfortable. So bottom line is, I'm not an expert on the outcome part. I'm pretty sure there's a growing body of evidence on it, mostly qualitative study, but I think it's, you know, this is the best we can have. And again, if the parents feel like it's better for them and for the baby later on when they are reaching the teenage or the adult age, they are feeling, we see a difference. I think that's a win.
Yeah, thanks so much, Laura. My second question was about the transition and continuing this neurodevelopmental prevention and care as they're discharged to the pediatric ward, and then also involving the ones that have the most chronic lung disease or neurodevelopmental issues will be readmitted to the PICU. And so in terms of carrying on that care, the transition period, do you involve teams from the ward coming into the NICU to get familiar with the baby that would be and exactly the specifics of carrying on the neurodevelopmental care?
So that's a key aspect. We know that every transition or every transfer is a big challenge for those parents. And it's the transfer between the antenatal and the postnatal period, but also going from a level 3 to a level 2 to the CHEO ward. Every time they have to change the team, they have to rebuild the trust, they have to re-explain the story and everything. So I think you're right. Our job is really to ensure that those transitions are as smooth as possible, and having this multi-D meeting, making sure parents are present, can visit the unit before the transfer and everything is key to support all those changes. But if you ask me, I think the preterm baby, they should stay in the NICU. If we have enough beds, which is not the case, those babies, they should stay in the NICU unless they have like a very specific, medical condition on the top of the prematurity that needs additional specific care we cannot provide in the NICU. But to me, like, our job is to bring those babies from birth to wherever they go and hopefully home. And that is also supporting them transitioning home. And so we have more and more program, especially in France now. We have inside the NICU, part of the NICU team is dedicated to go and do home visit. And so that means you can discharge the baby early, even with the tube feeding. And then it's going to be exactly the same team taking care of the baby during the NICU stay that will also bridge and go home. And that's for the parents. It's very impactful because they don't have to re-explain the story. They trust the people, and they know if something happens, they will be readmitted in the NICU. So to go back to your question, it's really about how we support the transition. My guess would be the best way is to limit the transition as much as possible, but this is what we have. And so if we need to change from unit to unit, I think we should work together and ensure those parents are part of the discussion, and we can, smooth the transition as much as we can.
Thanks, Laurent.
Thank you. And Nicole, please go ahead.
I'm coming back to the evidence. So there is a really big evidence if you look at WHO data in low and intermediate developing countries. It reduces the mortality by 50% when you do kangaroo mother care the way WHO prescribes, which is staying all day with the family, at least 18 hours in skin to skin per day. And in Benin, when I've been really involved, we have shown that for babies surviving the first week who go to kangaroo mother care 24/7 or stay in the unit, 9 out of 10 survive in the kangaroo mother care unit, when only 1 in 10 survives in the NICU. And that's because they have one nurse for 30 to 40 patients, and they have really no technical support. So it's easy to show a difference and evidence in when you have low resources, low nursing capacity, low technical equipment. But in our condition, when we have incubator, syringe pump, 1-to-1 ratio to 1-to-3 nursing patient ratio, it's really much more difficult to show that difference, and it will have to be on how the family develops caring for the child and how the child develops for the long term. But we have also shown that in Benin, we can send babies home when they are 1.2 kilo, which I was so frightened when we started doing that, but that's the best way they survive. They continue to do the kangaroo mother care at home, and they survive because they are with the mom and not getting infected and malnourished in the unit, which is the main cause of death. So I think we need to show that difference in our condition. We are way too technical and give place to the families, but we need to change our mind for that.
And I think one aspect, like to add to this comment, I think when you do something, an intervention, it's always the balance between the benefit, the expected benefit for the patient, and the expected risk. To me, developmental care, if it's done like in the right setting, again with a safe care, we have skillful professional for emergent care and everything. I don't see what are the expected adverse effects. So you know what I mean? Like, I don't think you need as much evidence, for example, for this compared to an intervention when you know this medication has a ton of side effects and you need to be really sure it's actually improving the patient. And I'm also a bit puzzled every time when in 2025 we are asking for evidence that a mom should be with a baby. To me, that's common sense, but it seems like it's always, we are facing a world sometimes where people are asking for more evidence.
Mm-hmm.
Great. Well, thank you again, Laurent, on behalf of everyone. Excellent rounds, and thank you all for your questions and attention. And we'll end the rounds today and let everyone move on and start their day. Okay.
Thank you, everyone. Bye.